Right. Thank you. Thanks, Jeremy. Thanks very much for that introduction. I'm going to put this on. It works on presenter view. Okay, so I'm hoping you just see with a single screen there. Yeah, thanks very much for joining. As anyone who sort of has worked with me knows that I'm a little bit obsessive about this topic, and I apologize for that, but this is the one time of the year or of 2 years where I get to talk about it incessantly, and I'll try not to talk about it too much outside of this time. This talk comes about, well, it comes about from a sort of lifelong interest in why we do tests, why we shouldn't do tests, and what sort of errors come about if people don't understand doing tests. And I put that all together into a book, and this is the cover of the book called How to Request a Test. It was published earlier this year by Oxford University Press, very short. And also I've recently put together a Substack with which is essentially a blog with topics, with posts about new tests, certainly some old topics about tests, but also some new tests, not just in infectious diseases, but things like things that are quite topical, like screening for colorectal cancer and what have you. And so that's sort of my background. And I'd like to begin, if enough people have joined, with I'd like to start with this question, because if you get the answer to this correct, then you can probably save yourself an hour and go off and do something more interesting. So there's a test in front of you. The sensitivity is known to be 90%. The specificity is known to be 95%, and it's positive. What is the probability that the patient has the condition? And you can vote now. And if everyone gets it right, then we'll stop. Okay, so we've got 33, 34, 37. Okay, lots of answers.
Yeah, so just 5 more seconds and then I'll close it. So you can see the results so far, Tom, but they can't.
I can, yeah, they can't. I can just see the numbers. You've done 42 have answered.
All right, so I'm going to end the poll and then show the results. Here we
are. Okay, so I'm just writing this down because I'm going to ask you the same question at the end of the talk and see if you give any different answers. And we've got 95%. Most people went for, or the highest number went for 95%, then 29%, then 92.5%, and then 24% said, I don't know. So that's what we've got. And I'm not going to tell you the answer right now. I'm going to ask you the question a bit later and see if we get any different results. Okay, so thanks for that. That's just a starter for 10. That is actually very much in line with what I've got when I've asked this question before. I'm trying to go forward one. Okay, so the next question I'd like to ask, again, sometimes works a bit better in person, but perhaps you can type your answers in the chat, and maybe Jeremy can just read a couple of them out. But this is a very naive question. I like naive questions because they people think that they're very easy to answer, but they're often not. And the question that was asked to me when I was a medical student, which sort of set me on this path, was why do we do tests? It's a very naive question. You can give sort of 1 or 2 word answers as to why you do tests, and then I'll put up some of the answers that are typical.
So I'll read as we come. So we've got one, because we need an answer, another to make a diagnosis, a third to exclude a diagnosis.
Okay, that's fine. I mean, just to get you thinking.
And then a couple more, so to confirm a clinical suspicion, they're floating in, and then to focus therapy or to refute or prove a diagnosis.
Yeah. So, I mean, good answers. These are all the answers that when I was asked this at medical school, the first person put their hand up and said, diagnosis, doctor. And the chap asking the question was quite nonplussed, because that's what people always say. And it's not wrong, of course. It is to make a diagnosis sometimes. And it's also, there are other answers like disease monitoring, things like monitoring treatment and deciding which treatments to give or what dose to give or what duration to give. Also sometimes do tests for research. And that's a non-exhaustive list, but just to get you thinking. And I prefer to, rather than use these terms, although I mean, we do use these terms and there's nothing wrong with it. I try to summarize it into a single line, which is that we do questions, that we request tests in an attempt to answer patient relevant questions. And outside of sort of research settings and in the sort of tests that I'm talking about, which are tests done essentially in hospitals and clinics by doctors and nurses, I think there is always a question that you can come up with which you're attempting to answer. Now, that might be a related to diagnosis or monitoring or something else, but many tests answer questions that are more than just one thing. So if you, for example, think of when you do a biopsy for cancer, you might biopsy a lump and you might see something that looks like cancer and you've made your diagnosis, but you also get prognostic information. You get a grading of the tumor. So you'll get diagnostic and prognostic information. Similarly, if you do a test like a gastroscopy, you might be able to make a diagnosis of varices, but you might even actually have a therapeutic element where you might be able to, so this test might actually also be a therapy. So I prefer to summarize it as answer patient relevant questions. And those questions, I think, always have or should always have two strands to them. The first is, what do you want to know? That's quite easy. I want to know the hemoglobin of this woman with fatigue. I want to know, I want to know if there's air under the diaphragm in this patient with abdominal pain. What you want to know is usually quite easy, but the bit that's sometimes missed is, why do you want to know it? And this is crucial. You want to know the hemoglobin in the woman with fatigue because you know that's a common cause of fatigue. And if it is low, then you'll be able to look for an underlying cause that you can treat. And if it's not low, then you can start looking for other causes of fatigue. But often, I mean, one of the mistakes that can quite commonly be made is that people decide what they want to know, but they haven't formulated a good question in their mind as to why they want to know it. So I'll just keep that in mind as we go through, because we'll come across some questions further along. And just to sort of complete the introduction, the next question is, well, why should you really care about tests? I mean, they're relatively cheap. You know, as a doctor, you often just tick boxes and someone else does it for you. And if it doesn't change the management, it doesn't really matter. Well, it's not really true. The costs are very, very high. So just to give you some numbers, like 17 years ago, there was a very good survey in the UK where they spent £2 billion a year. So something like 45 billion rand. That's nearly 20 years ago. You can at least double that now. So something like 100 billion rand a year on tests. And when people had a look through to see if they were useful or not, they found that at least 25% of these tests were not useful. And other times, up to 70% of tests are shown not to be useful. So it's easy to forget about costs, but particularly in a country like this, if you're spending money that you don't need to spend, then there's less money available to do the things you really need to do. So we always need to be conscious of the money that we're spending. Of course, tests can cause harm to patient in obvious ways. If you need to do a brain biopsy, then you have to obviously put someone to sleep and drill a hole in their skull and take a piece of their brain. That's clearly causes harm. Those sorts of harms are relatively obvious. Ionizing radiation, things like that. That's clear. That should be taken into account when you think of a test. But also, I think what's under-recognized is the side effects of in terms of interpretation, and particularly when new tests are introduced. And I'm going to give you an example of that. This is rather long, but I'm going to read it to you. It was published nearly 10 years ago in the South African South African Medical Journal, and it begins, the World Health Organization recommends expert MTB-RIF as the first test of cerebrospinal fluid from patients with suspected tuberculous meningitis. A 43-year-old HIV-positive man presented with 2 weeks of headache, recent onset slurred speech, inability to walk, and impaired consciousness. A CT brain scan showed mild hydrocephalus and basal enhancement. CSF was yellow with 300 lymphocytes, protein of 1.06, and a glucose of 1.3. The expert MTB-RIF was negative. the admitting doctor discounted the diagnosis of TBM and prescribed ceftriaxone. The patient deteriorated and died 4 days later. Now let's just do the same scenario, but take away the WHO recommendation and the test. And the test results. A 43-year-old HIV positive man presented with 2 weeks of headache, recent onset slurred speech, inability to walk, impaired consciousness, a CT brain showing hydrocephalus and basal enhancement, yellow CSF with 300 lymphocytes, protein 1.6 and glucose 1.3. I think it's pretty clear that whilst an experienced doctor would have discounted the negative expert MTB RIF, the inexperienced doctor didn't. And that's why it was written up, because the inexperienced doctor thought that because the expert MTB RIF was negative, that TB meningitis was excluded. If you hadn't given that inexperienced doctor the test and you'd simply presented it in this way, I think the vast majority of even inexperienced doctors would have considered TB meningitis and then started therapy. So it's important to realize, I think, that putting tests into people's hands when they don't necessarily understand their limitations can have real and serious side effects, essentially, for patients if we don't get it right. So these are all really the reasons I think that it's important to understand testing. So just moving on to, before we come to some more specific patient-relevant questions, the first question you ask when you're presented with a new test, and although I said tests answer questions, I'm largely talking about tests that we're using to try and make a diagnosis in this talk. That's largely, although the principles apply for other things like prognosis, monitoring, mostly we'll be talking about making a diagnosis and initiating therapy or excluding a condition. So first thing we need to know if we've got a test in our hand is its accuracy. And to know its accuracy, we have to do an accuracy study. And this list is really the list of things that should go through your mind when you think about performing a diagnostic accuracy study. As with all evidence-based medicine, you begin with a question. And I'm going to give you an example, a very nice example of how this was presented during COVID in terms of what you want to know from your study, what test and what level of accuracy. Crucially important is the population that you're doing the study on, because if the population isn't well defined, then we don't know. Just as in a study of a new drug, if the population isn't well defined, we don't know if the results are going to be applicable to our patient in front of us. We next have to very clearly define the index test. That's the test that we're trying to evaluate. Clearly define the condition that we're interested in. And then the most difficult area often is the reference standard. People often like to use the word gold standard to talk about reference tests. I think that's not a particularly useful term. Gold standard sort of implies that this test that the reference test you're using is perfect, always gets the correct answer. It's gold in that it never changes. It will always be the best test, and few of those things are true. The reference standard is what you use in your study. Now, you obviously would like to use the best possible reference standard you can attain, but sometimes for reasons of cost and sometimes patient-related factors and ethical factors, the reference standard that we use is far from ideal. And that needs to be, whatever you decide to use, needs to be determined in advance. And then when you're doing a study, you need to know what actions are going to change. That's really the why of the question, how your tests are going to change your actions. And I'll just give you an example. This was of how a very skilled group present this. This was a rapid review in the relatively early days of the COVID pandemic, but it's good for illustration by the Cochrane COVID Diagnostic Accuracy Group. When they present their results, they use these headings. And the question is, what is the diagnostic accuracy of rapid point-of-care antigen and molecular-based tests for the diagnosis of SARS-CoV-2? The population was broad. It was adults or children with suspected SARS-CoV-2. The index test was actually focusing on rapid antigen tests, but also molecular tests, focusing on rapid antigen tests for the diagnosis of COVID. Target condition was COVID. And the reference standard they used for positive cases was a RT-PCR that was positive, and for negative cases, a negative RT-PCR. And possibly controversially, they also used pre-pandemic samples as a negative reference standard. And the action to be taken, the problems if we get a false negative were missing cases of COVID infection, with the risk of community transmission. This was really before there were any known therapies. And a false positive would lead to unnecessary isolation and quarantine, with the potential for new infections to be acquired. So that's how you present a test. And it gives you some idea of how you test a test, in that you need to go through all of these in turn, paying particular attention to the reference standard. I want to just highlight an area where, if you're looking at tests of tests or accuracy studies, where it's easy to be misled. And those are, rather than what we just described, which is when you take a whole population, you perform the index test and the reference test on everybody in the population, and then you apply your results to that population. What we commonly see are a different design called a case-controlled study, where rather than taking a population at risk and testing everybody with both tests, we take a group of people who are definitely known to have the condition and a group of people who are definitely known not to have the condition, and perform the study. And it usually looks very impressive. When we do those studies, the test looks very accurate. And I'll give you an example just to take it to absurdity to show how these things can go wrong. Is imagine that you had a new urinary pregnancy test, and you wanted to know whether it was good at determining pregnancy or not. And you chose as your population, because it was very convenient, you went to an antenatal clinic where there were 10-week dating scans going on, and you chose couples walking out of the room looking happy as your group. And you decided that the one who looked like a woman was positive for pregnancy, and the one who looked like a man was negative for pregnancy. And you did your test on those groups. You had a group of positives and a group of negatives. Now, it wouldn't be surprised, you wouldn't need an absolutely amazing test to show that you were very good at determining pregnancy in those two groups. For example, a measure of testosterone would work very nicely, in that people with low testosterone would be pregnant and the people with high testosterone would not be pregnant. And so if you do a test in a case control way like that, whether essentially the negative controls are people who are very, very unlikely to ever have the condition, then you get very optimistic results. And in what I describe, if your urinary pregnancy test was shown to work well and be accurate, you wouldn't suddenly go to the regulators and start to get it approved. The reason for doing the study really is because in case it doesn't work. So if a pregnancy test can't tell the difference between men and women, even pregnant women and men, then it's very unlikely to work in the group that you want, which is women who think they might be pregnant. So these kind of studies are much cheaper to perform. And if they show poor accuracy, then you might drop the test. But whenever you're reading a diagnostic accuracy study, be very careful at looking at whether it's based on a population or whether it's based on case control. Okay, so we've discussed why we do tests. We've discussed what a diagnostic accuracy study looks like. I'm now going to look at the how we describe the accuracy once we've done our study. So in the simple example where we've got a binary condition, it's either there or it isn't, and we've got a test that's either positive or negative. When we've done our study, where we've performed the index and the reference standard on all participants, we've got 4 possible outcomes, which you'll probably be familiar with. It's typically shown in a 2x2 table. You've got those who are true positive, those who are reference standard positive, i.e. definitely have the condition, and test positive. Those who are reference positive and test negative, that's a false negative, that's C. those who definitely do not have the condition on the right-hand column, you've got those who test positive and then who test false positives, and then the last are the true negatives. But that's the simple outcome of a study of a binary test for a binary condition. And so what can we draw from that? Well, we can draw what we like to draw, which is the sensitivity and the specificity. So what question, I said that tests answer questions, what question does sensitivity answer and what does specificity answer? If I just go back one, sensitivity is from the first column in people who definitely do have the condition, A over A plus C, and specificity from the second column is in people who definitely don't have the condition, D over B plus D. So sensitivity answers the question, in patients who definitely have the condition, what is the chance that the test is positive? And specificity answers the question, in patients who definitely do not have the condition, what is the chance that the test will be negative? I think it doesn't take a rocket scientist to see that these are not questions that we ask very often, if ever. If somebody were to walk into your consulting room and say, "Doctor, I have definitely got tuberculosis. What is the chance my test will be positive?" then you could confidently answer them with the sensitivity. That would be answering their question. And the same for specificity or the reverse. But clearly that never happens. And so what I'm really trying to highlight is the drawbacks, the limitations of using words like sensitivity and specificity. We do use them. I use them. They're not to be thrown away. But the point is that these numbers answer questions that we almost never ask and are essentially not patient relevant. So I'll just do a second poll, if I may, because I think this is important. I don't think it's something I emphasized when I was sort of writing the book, about what you think, how do you categorize sensitivity and specificity? Do you think they're intrinsic properties of tests? Do you think they're results of diagnostic accuracy studies? Do you think they're neither of those? There's something else, or do you think they're both? I'll have a quick quiz.
Yeah, let's give another 5 seconds. Okay, ending the poll and sharing.
The poll and share. So half of you say they're the results of diagnostic accuracy studies. 13% think they're intrinsic properties of tests, or both, 30%. So for me, the important point is that they are not intrinsic properties of tests, as I think is often taught, as if a sensitivity and specificity is something that a test carries with it. It isn't. It's something which changes dramatically, and I'll show you some examples of how it changes depending on the diagnostic accuracy study that was done. So for me, the answer is B, and half the people got that right. And let's just take, I mean, I'll show you some examples, but of how these things vary, but just think about tests that we do in infectious diseases, for example. Think about CSF cryptococcal antigen test. Now, if you perform that test in a group of patients who are known to never have had cryptococcal meningitis before, and we're asking the patient relevant question in this patient with meningitis symptoms, do they have cryptococcal meningitis or not? Because if they do, I'm going to want to treat them with antifungals. We know that test performs very well, has both a high sensitivity and a high specificity using those terms. Now to apply that same test to a group of patients who have recently recovered from cryptococcal meningitis, and apply that test now, what's the sensitivity and specificity like? Well, we know that the specificity is terrible in that group of patients, because we know that the cryptococcal antigen stays positive for a long time, regardless of whether you've got meningitis or not. So it couldn't possibly be that CSF CRAG has an intrinsic sensitivity and specificity. What it has is diagnostic accuracy dependent on the population of people that you're studying, and therefore dependent on the diagnostic accuracy study. Another example which came up recently when I was discussing testing people in rural Eastern Cape for schistosomiasis, you're using dipsticks of blood in the urine, If you test that in sort of under 10-year-olds, it works fairly well, but you test it in menstruating girls, and suddenly the specificity is terrible because you detect blood in the urine. So the summary I'm trying to make is that sensitivity and specificity are nothing more than the results of diagnostic accuracy studies. Not shifting. Okay, just to give you an example from our area, this is Karen Steingart's systematic review of diagnostic accuracy of expert MTB RIF, not ultra, and each one of these is a study, is a different study, and and on the right hand side is the specificities, which are remarkably similar, but you can see the sensitivities in the left hand blue dots vary dramatically from as low as 58% up to 100%. And you can do a meta-analysis and come up with a figures of overall the sensitivities 89 and specificities 99. But I think you can see from this that these values vary dramatically. And this is the same test on very similar populations, patients with suspected TB. When you start doing it on more diverse populations, you find that these values vary even more. Something similar for specificity, which you'll be aware of. This is a change in specificity within the same study. This isn't a group of studies. This is one study, and many of you will know that expert and expert ultra can remain positive after someone's completed treatment for TB in the absence of what we consider to be disease. And in this case, this is looking at on the x-axis the number of years since completion of treatment and how the specificity improves over time, even within a study. And you can see on the left-hand side that within a year or so of completing treatment, the specificity is really very poor, around 90% or 85%, rendering it relatively useless. But just goes to show you that how you think of the accuracy of a test depends very much on the person that you're testing or the population that you were testing when you did your study. So is there a better way of doing it? So I said that sensitivity looked at the first column, specificity the second column. What about looking at the rows? What about looking at people who test positive? Because this is what we're really interested in, are people with positive tests and people with negative tests. So if we look at the rows rather than the columns, we can come up with predictive values. And this seems to answer our question, because a positive predictive value, which uses the first row in patients with a positive test, answers the question, in patients with a positive test, what is the chance that they have the condition? This is a highly patient relevant question and answer. And if the positive predictive value is 90%, then the patient has a 90% chance of having the condition. That's intrinsically helpful. Negative predictive value is also helpful in that it answers the question, in patients with a negative test, what is the chance they do not have the condition? Again, if that's 99%, that's very useful. So why this over-reliance on sensitivity and specificity at the expense of predictive values, which seem to be much more intrinsically useful? Well, the answer is summarized in this slide, that predictive values vary between 100 and 0, depending on the prevalence of the condition that you're studying. So this is the two curved lines, ignore the vertical lines, straight vertical lines, are what are the predictive values that you get if you consider a test with a sensitivity of 99% and a specificity of 96%. On the far left-hand side, when the disease prevalence is 0, the positive predictive value is 0, and the negative predictive value is 100. But as you move across, these two change in a not particularly obvious way until you get to the far right-hand side, when if everyone has the condition, then the positive predictive value must be 100% and the negative predictive value 0. So predictive values sound great, but they're only, if you say the positive predictive value is 90%, you must always say in a population with a prevalence of X or Y. And one of the commonest misnomers that you see in the literature is people say the negative predictive value was quite good when the disease prevalence was low. I mean, you can see what a nonsense statement that is. All negative predictive values are good when prevalence is so low. by definition. In this graph, you can see everything on the left-hand side, the negative predictive value is high, or positive predictive value was high when the prevalence was high. You see this often in the discussion of studies of diagnostic accuracy, and it means almost nothing, because it's really telling you what's on this graph. So if sensitivity and specificity are not particularly useful, predictive values are potentially useful but vary with prevalence, what's the answer? And the answer is potentially, at least for individuals, comes from Bayes' theorem, which you may or may not have heard of. It's a whole sphere of mathematics, Bayesian mathematics, but I can only understand it in very simple terms. And what it really means is, in this context, is the updating of a probability of a condition based on a test result. So what that means is you have to begin with a pretest probability. What's the probability of a condition existing before you do the test? Now, I've used a plus sign when I say add the test result with a pinch of salt, but combining it with the test result, you then get a post-test probability, and that is the basis of Bayes' theorem. And this can help you, in an individual, go from find out the post-test probability, which is the probability that this individual has the condition. So to do that, you need two things. You need the pretest probability and you need the test result. Pretest probabilities, I'll use an example, not from infectious diseases, but a very well-known one, is the Boyles criteria for pulmonary embolus, which I remember sort of learning 20-odd years ago, which is a point scoring system for features of pulmonary embolus, and you add the points together and it gives you a probability. That is what you might consider if you were considering a test like a VQ scan or a CTPA. You might consider that to be the pretest probability. And there are similar rules in infectious diseases, and when I'll show you one just now in PCP, also in TB and in others. A lot of the time, these sort of rules don't exist, and pretest probability comes down to intuition and experience. And that's something that obviously only comes with time. But if you want to use this method, then you have to come up with some way of estimating pretest probability. I definitely don't want to labor the maths because the maths are largely irrelevant. But when I say adding the test, you use a Bayesian factor, which is known as a likelihood ratio. You really don't need to worry about this. This is what I mean by adding the test. Likelihood ratio positive is the ratio of sick people with a positive test and not sick people with a positive test, and the reverse for negative likelihood ratio. The numbers come out. So if you look, I've given the ABCD. If you look at these, they are derived from that 2x2 table I showed you. So they have all four values in them, unlike sensitivity and specificity and predictive values that only use two of the values. Likelihood ratios use all the values, but of course they have the same drawbacks in that if the diagnostic accuracy study was poor or was performed on the wrong population, then the likelihood ratios will also be poor. So that's something that must always be borne in mind. So each test, binary test, would have two outcomes: a likelihood ratio positive, which is the number between 1 and infinity. The higher the number, the better the test at increasing the chance of the condition being positive when the test is positive. And the likelihood ratio negative, which is between 0 and 1, and the value closer to 0 means it's much better at decreasing the probability of the condition with the test. But you don't need to know about this because if you want to determine the probability of a condition, you simply need to go to a web-based or an app-based calculator, and this is what I do. This is the one, my preferred one, and in the box I've simply said, and I'm also struggling to see it, but I've said that when the prevalence or the pretest probability is 5%, the sensitivity is 90%, and the specificity is 95%. I've used those because they can be used to calculate likelihood ratios. And you press compute, it gives you an answer. So for this theoretical patient with a 5% chance of having a condition pre-test, with a positive test, it gives you the likelihood ratio and the post-test probability of 49%. And similarly, the negative likelihood ratio and a 1% chance of a negative test. So that's how you would go about working that out for an individual. you saw on the right-hand side this diagram, which also has these lines drawn from the 5% on the left. It goes through the likelihood ratios to the post-test probability on the right. And this is another picture of that's called a Fagan nomogram. And the important aspects of this, firstly, is it's obsolete for making these calculations, because you don't need to have a printed piece of paper in your pocket and draw a line with a ruler. You can use an online calculator. But what it does do is it shows you some of the properties of Bayes' theorem, which are very important and often neglected, which is that if you look on the left-hand side is pre-test probability, the right-hand side is post-test probability. What you find is that the numbers crowd together around 50%. And then on those scales, they're much more spread out at either end. And this is a fundamental principle of testing, in that for a given test, shifting the probability from pre to post works much better when the pre-test is around the 50% mark, and much worse when the pre-test probability is at one of the extremes. It's worth sort of laboring that point. So essentially, for a given test will work less well at an extreme with a very low or very high pre-test probability than when it's in the middle. This comes to the fore when you think of screening, for example. A screening test is typically when you're looking for a needle in a haystack. You're starting with a large group of people with a very low probability of disease, maybe as low as 1 in 1,000 or 1 in 10,000, and then you're applying a test to try and typically not to make the diagnosis completely, but at least to improve probabilities. Screening tests have their odds are against them from the very outset, because they're always working from very low probabilities. And so that's one of the reasons that screening is controversial, and why so many screening programs have been shown to not be effective. Okay, joining for time. So I just want to talk about what we do with the answer. So we've sort of talked about how we might come to a pretest probability, either with a calculator or by intuition. And then we may have an idea of the likelihood ratios, and we end up with our probability of disease at the end. But just knowing the probability of the disease doesn't tell you whether or not you should treat the person or discount the diagnosis. I put this picture up because it's from a classic paper published in 1980 by these people, Paul Kinsera, in the New England Journal of Medicine, which was a follow-up to a paper 5 years earlier, describing the very basics of how you come to make a medical decision. I would encourage you to read it if you have the time. But essentially what they said was, they used the example of someone with some renal impairment and hypertension, and they wanted to know the answer to the question, should this person have a renal biopsy to look for a steroid-responsive renal disease, or should they have, or do they actually just have hypertension-related renal disease that does not require steroids? And they essentially divided the probability of the disease from 0 on the left to 1 on the right. And by doing some calculations on the accuracy of the test, they showed that on the left-hand side, the probability, when the probability of disease is low, if you do the test, even if the test is positive, it doesn't shift the probability enough that you would add treatment, so that you would start treating the patient. And similarly, on the right-hand side, if the pretest probability is very high, even a negative test won't be enough to discourage you from doing treatment, offering treatment. And only in the hatch zone in the middle does the test have the potential to influence your management in terms of treatment or not offering treatment. And this is, again, a kind of fundamental point, something that we published in a discussion about TB meningitis, to bring it back to infectious diseases, in that when the pretest probability is very high, and that line is called the test treatment threshold, we will treat the patient for TB meningitis regardless of the test result. A little bit like the example we showed you with the negative expert on CSF, is that so in effect, in that zone, in the upper reddish zone in this picture, discounting the issue of rifampicin resistance, which always comes up, but in a test that was simply telling you whether or not someone had TB meningitis, the result of the test would never influence your decision to treat, because if it was negative, you would still be in the red zone and you would still treat the patient. So the test essentially can't change management. Similarly, at the lower end, if the pretest probability of a condition is very, very low, even if the test is positive, you basically don't believe the result and you don't offer treatment. And so again, a test is not necessary. But in the middle is the region where tests are useful, which is helpfully the region when tests work the best, around typically close to the 50% probability. These numbers are not correct for TB meningitis when the numbers are much lower. You treat someone at a much lower probability, but it gives you the idea that tests are there as tiebreakers typically when the probability is somewhere in the middle zone. So I see I'm wobbling on and going over time. So what I'd like to do is come to something very specific to infectious diseases that we work in, and look at the diagnosis of pneumocystis pneumonia in HIV. And this paper by Gary Martins from 2018, I think, where up to this point there had not been good advice for how and when to treat people for pneumocystis. The WHO advice had simply been, if you look at the official documents, consider PCP treatment in patients who are sick. But Gary and the team performed a study where they looked at patients who met the definition of being seriously ill with HIV, were admitted to hospital, and again, it's beyond the scope of this talk to show how how these models are generated, but essentially they generated a model similar to the Boyles criteria, with scores on the right of 3, 1, and 2 for chest X-rays with possible or likely PJP. The limitation was that this was an expert chest radiologist, so that does rather than one of us. But so there obviously are limitations. A hemoglobin greater than 9, not something that you would intuitively think made pneumocystis more likely, but was an independent predictor in this group, largely because those who were seriously ill with a low hemoglobin had TB, and a saturation on room air of less than 94%, giving you a possible score of 6. And this is what the results look like. If you look on the top, this is they gave different models, but this saturation model is the best. If you look on the top, you can see that people who scored 0 had a 0 probability of PJP. And this was a lot of them. This was 135 people out of about 400 scored 0 and had 0 probabilities. This makes this kind of model extremely useful, particularly as it's done in our setting. But for different scores on the left from 0 up to 6, you can see that there were different probabilities ranging to, if your score was 6, then your probability was 66%. And they also give the likelihood ratios and the sensitivities and specificities. So this, in my view, is the first action that you should take when considering PCP in our setting. Just to go back, you should, not that these are the only things to consider, of course, but there are other factors that you should consider, but what the chest X-ray looks like, what the hemoglobin is, and what the saturations are key. And only then and only then should you consider tests like beta-glucan and PCR tests. What we frequently see is the opposite, is that people see a patient who's sick and they request a beta-glucan and a PCR without doing this first. I've given you some approximate likelihood ratios for those tests. That's PCR of bronchial alveolar lavage fluid and a beta-glucan. And they have sort of moderate diagnostic accuracy. But what I want to show you is this next diagram, which is called a leaf plot, which explains what's actually going on in these patients. Now, it's a bit complex, but I'd like to talk you through it, if I may. The dotted line from bottom left to top right, that is the pretest probability of a patient. When the test is positive, and those lines 1 to 6 are the line what I showed you. 0 to 6 are what I showed you on the table. Those black lines intersect on the 45-degree line at those points. If the test is positive, this is a beta-D-glucan is positive, then the probability goes up from the 45-degree line up to the red line. And this is actually another nice illustration of what I said earlier, in that tests work much better around the 50% pretest probability. You can see that that red line bows out at around the 50%, and changes in probability are much less at the extremes. The blue line, curved line below, is what happens when the test is negative, and gives you the post-test probabilities when these tests are negative. So I also put this into a table to give an idea of how we might approach this, in that if we work out the pretest probability, if it's 0, and like I said, that's like 40% of these cases, there's no need to perform a beta-D-glucan. The probability is essentially 0. We can exclude the condition. When probabilities are more moderate, in the sort of 1, 2, 3, 4 zone, a negative beta-D-glucan reduces the probability into the blue zone, into the green zone, which is below 3%, and it's reasonable to exclude the diagnosis. Again, on the right hand side, if it's positive, if the score was 1, then it increases the probability to 15%, and then that's probably considered equivocal, and a PCR would be reasonable. The other green on the right hand side, the green ones, when beta-D-glucan is positive, would be enough to treat without doing a PCR. Now, this is just a potential guide. It gives you an idea of when you might do a beta-D-glucan and when you might go on to do a PCR. Although if you just look at the bottom 2 rows, where the scores 5 and 6, although a negative beta-D-glucan would reduce the probability down to 5% or 11%, the chances that it will be negative are very small. And so the yield of that test is very small. And that's when you need to start thinking about the costs involved. So if you've got somebody with a score of 6, an obvious chest X-ray, preserved hemoglobin, and a hypoxia, the chance that the beta-D-glucan will be negative is minuscule. And although I've given it an a pink here to do it, it's probably not worth doing. So sort of a slightly garbled approach to how you might consider using tests. You can see they're much more useful in the mid zones when things are equivocal, and there are times when they're completely not useful. And the point I would make is that these types of tests should only be requested when the initial workup has been done. Similarly, for TB meningitis, we often see people requesting expert ultra of CSF before they've seen any of the other results. It doesn't make a lot of sense. Quite often, when you get the first set of results back, you'll be able to make a diagnosis or exclude it or exclude a diagnosis. And an expert MTB-RIF is only going to be useful in those cases where where things are equivocal. Many patients, it will be clear that they definitely do have TB meningitis, in which case the test is of limited value other than rifampicin resistance, and in others it will be very clear that they have a different diagnosis. And so we see very many of these very expensive tests being done when they have no potential to influence management, and that by simply waiting until the initial cheap and easy information is available, we can make a much more rational test request decision. So I'm coming to the end of my time. This is what I put at the end of my book about things a checklist to go through in your mind every time you request a test. And of course, you won't do this every time, but certainly if you're thinking of an expensive test, the first thing to do is to formulate your patient relevant question. What do I want to know, and why do I want to know it? And then the next thing to do is to ask yourself whether there's a possibility your test can answer this question. Now, it doesn't have to be that it will definitely answer the question. You could do a test where a positive result influences your management and a negative test doesn't. That test still may be valid. But in order to determine if it can answer the questions, you need to have some idea of the pretest probability, which may be done by intuition, and you have to have some feeling. You may well not know the exact likelihood ratios, but you have to have a feeling for whether this test has the possibility to cross those thresholds and change your decision from treat to not treat or vice versa. There are other things to consider. Firstly, the obvious financial and human costs, which can mount up. The opportunity costs of doing tests in terms of things like delayed treatment can be significant. We discussed the physical costs and also significant psychological costs that come along with some tests. We also discussed the indirect costs if tests are poorly interpreted. And then something I alluded to in the PCP example is the yield, which really relates to costs. Now, a test might be very easy. The blood may already have been taken, or whatever sample may already been taken. It may already be in the lab, may not have a particular cost to a patient. But if the chance that it changes your management is tiny, 1 in 1,000, then although it has the potential to do so, it probably isn't a good use of resources. And then I always say, just stop and think, sum those things up the best you can before you make your decision. The last slide before I ask you your question again is, what are the sort of common errors that I see repeated? The first one is people's question is, I just want to know the answer. I just want to know the answer is a very lazy question. And we don't have the resources to answer questions just because the doctor wants to know the answer. Often there is a reason that the question is reasonable, but you should think hard about what that question is and how it's important to patients, either this patient or possibly a future patient. If you think about an autopsy study, we don't do that for the patient in front of us because they're dead, but we do it for a future patient. So that might be the reason that you want to know the answer. Try not to be a tick box zombie. It's very easy just to tick boxes on charts these days because someone else is going to do the testing and pay the money. Try to think carefully before you tick boxes. Double dipping it applies to asking for multiple tests that essentially answer the same question. The classic one being asking for ALT and AST on the same patient. I'm not saying there's never a reason to do that, but it's rare. ALT gives you pretty much all the information that you want, and AST is rarely adds value. Not never, but rarely. Just some of the bugbears from infectious diseases are when people perform tests before they've thought about patients, and this really drives everybody nuts. When somebody asks you to see a patient because the procalcitonin is 10, this is never a good question. Not with something like procalcitonin. It might be with potassium. The potassium is 8. I really want to know, but you see this patient might be reasonable, but in infectious diseases, tests like this are never the reason to see the patient. The patient is really sick. Give me the story. I really want you to see them. Oh, and by the way, the procalcitonin is 12 might be reasonable, but we never want to hear about these tests before we've heard about the patient. We also, what we see commonly is people requesting tests which are good monitoring tests to be used for diagnosis. CRP is well studied. It does have some value in screening, for example, and decisions to use antibiotics. But in patients with sepsis who are clearly very sick requiring antibiotics, the value of the CRP is effectively 0. If you work in a high resource setting, someone will tell you that a drop in CRP of X over so many days is relevant, but in real life, it's really of not any value. So similarly, tumor markers, something that we see people requesting because they don't know what's wrong with the patient, request a set of so-called tumor markers. These tests are only really useful in people largely with confirmed conditions. So if I've done my job correctly, I can retake this poll. Just to remind you, it was to beginning, it was 29% A, 33% B, 14% C, and 24% D. You can see I've scared you off because there's only 28 people left.
Everyone's a bit nervous. So we can't see your specific result. We only see totals, if that reassures you in the slightest. So you're welcome to guess ahead and answer. So we'll give another 10 seconds and then I'll stop the poll and show the results. Okay, ending the poll. Here's the results.
Okay, so an improvement. So the answer is I don't know. And maybe I should adjust my talk because I managed to shift from 24% to 35%. The probability that a patient has a condition is not something you can know just from the sensitivity and specificity of the test. You can only know it if you also know the pretest probability. And as I said previously, determining that is something you can do using a diagnostic test calculator, but it's not straightforward. It's not something that is easy to calculate in your head. I showed you that example before when I gave a pretest probability of 5% and some diagnostic accuracy. But please don't go away from this thinking that if the sensitivity is 90% and the test is positive, the patient has a 90% chance of having the condition. If we were talking predictive values and we were talking about the positive predictive value is 90% in a group of patients with 10% prevalence, and your patient is from that population, then that would be the correct answer, but that's very, very rarely the case. So I'm glad I managed to shift a few people. Apologies for those who I didn't manage to shift. I will go back to the drawing board and think of more smarter ways of presenting this topic.
Cool. Thank you so much, Tom. That's it's not. I think it's a very, very tough thing. I mean, it strikes me as something which, given its absolute sort of centrality to most of what we do, or much of what we do as doctors, really needs to be part of undergraduate curriculum, you know, and every step thereafter. I don't know if it's there now. I certainly didn't have it when I was an undergraduate at UCT, but maybe that's just UCT's fault. No, I'm kidding. But I think it's yeah, it's interesting and really fascinating. There's a couple of really good comments. So Stephen Korsman, I'm going to just ask you to unmute in a second, but you've mentioned he's a virology from UCT. Mentions he's, in terms of tick box zombies, he's had hepatitis virus requests all the way up to H, which I think is pretty good. But he made a very good point about he says he prefers the terms analytic sensitivity versus diagnostic sensitivity specificity. Stephen, do you want to elaborate on that?
Yeah, in the lab, what we focus on as pathologists and diagnosticians or laboratory diagnosticians is all we can really say is what the analytical sensitivity is or specificity. And that is basically the ability of the test to detect a given concentration of a specific analyte or more. So an example, let me take JC virus causing PML. Imagine that you've got a PCR in the laboratory that can detect one or more copies in the sample, of one or more viruses in the sample. What we're going to do in the laboratory is we're going to test a whole bunch of negatives and a whole bunch of positives, and we're going to see that 100% of our negatives test negative simply because the analyte isn't there. And the laboratory validation then says the test is 100% sensitive, or yeah, because it picks up all the positives and it doesn't cause any false positives. So it's 100% specific as well.
Specific.
Yeah. So, but it counts for sensitivity and specificity. So that's analytical sensitivity and specificity. But then you take your you have to do this in a clinical setting to figure out what is relevant to the clinicians. And if you take a population of 100 patients with PML and you get, using the same PCR, you get a 50% are negative and 50% are positive, that I would call a diagnostic sensitivity, because we know a lot of PML patients do not have JC circulating in the CSF. And we would call a sample like that, we would call a true negative based on analytical sensitivity, but we would call it a false negative based on diagnostic sensitivity or clinical sensitivity. That was just my point. I hope that makes sense.
Yeah, no, I agree with you, Stephen. When I wrote, I tried to stay away from those laboratory things in the book, and I say these tests, these have already been done, and I'm really talking about from the point of view of the doctor standing at the bedside rather than the laboratory pathologist. But I think you're 100% correct.
There's a few people are sharing their pain in the chat about, about various testing foibles, and there's a question which I think might allow you to summarize some of the topics. So the question I got sent was: is there an optimum pre-test probability that makes a positive test highly likely indicative of a disease? So I guess that.
Oh yeah, I mean, just to reiterate that a given test with a given, as Stephen would tell us, laboratory analytical capacity will shift probability more when the pretest probability is around 50. But it depends at what your threshold. I didn't dwell on thresholds, but it depends what your threshold for treatment is. Somebody with a possible TB meningitis, I would probably treat a person if I thought they had a 5% chance of TB meningitis. I would probably treat them, given that not treating them is certain death, pretty much, and treatment is reasonably well tolerated. And there's a whole science on how you come up with that figure, which I could bore you about for another hour. But in that case, you're really interested in testing people around about the 5% threshold, even though the test worked less well at that point. If that kind of answers your question, the testing is going to be around that threshold for whether you're going to offer treatment or not. For a different condition, that threshold will not be 5%. It'll be much higher. If we're treating someone with a common cold, if we had some treatments for it, you wouldn't be too worried about missing a treatment in someone with a less severe condition. So the answer is it depends on the condition and the threshold for therapy, but your test will work better if the pretest probability is around 50%.
Oh, thanks so much, Tom. So we're going to have to stop there just for time, but just two things. One is, as all these talks are, we're going to put this on YouTube the next day or two. Please have another look at this. This is really important. And then the second thing is, Tom, you didn't ask, but I'm going to ask for you. If people are interested in getting hold of your book, how can they get hold of it?
I'm happy to send people a copy, but if you did want to buy one, you can just Google how to request a test, Tom Boyles, and it's available online with some videos as an ebook. Or I actually have copies that I can send you at cost price. If you send me a message, you can find me easily, I think, through the Insta group or whatever. Or if you really want to, you can order one. But it's easy to Google.
Thanks. And sorry, just one other question just popped up, but I actually think it's again a good ability to sort of clarify some things. You may have seen the rational clinical exam. It was a set done by JAMA, I think it was, and they really reporting mostly sensitivity and specificity for clinical signs. And the question in the chat there at the bottom is, how do you feel about integrating that into clinical practice? I mean, it really talks to the same question you've been mentioning, but maybe give you another crack at it.
Yeah, I would just say that clinical signs are tests in exactly the same way. So again, it's, if there is a sensitivity and specificity for feeling for a spleen, but as with any other test, what it means depends on the pretest probability of there being a big spleen to feel in the first place. And so I much prefer people to just talk about in Bayesian terms about the chance before I did the test was this and the chance after was that, rather than sensitivity and specificity, which I hope I've explained can be quite misleading, particularly when pretest probabilities are at the extremes. So just to use another example, often hear people say, well, the specificity is 95%. That's not bad. Well, actually, the specificity of 9% is often very bad. If a condition is rare, in the single digit percentage, and you have a test with a specificity of 50%, you end up with at least 50% false positive results. So, these terms can be really quite misleading depending on so if you're not thinking pretest probability and shifting that probability, then I just think you're liable to have mistakes.